Oh, no, 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 you don't have to do that. Thank you so much, Carla. And I'd like to thank Carla, Susan, the entire organizing committee for this meeting. But most of all, the people who are here. You either forgot your sunblock and didn't want to be at the pool, or you're actually here trying to listen to the speakers that follow me, who are going to present some very interesting information. But what I'm going to do for the next 25 or 30 minutes or so, we'll go over the use of registry data in regards to what went on during the COVID pandemic, with specifics looking at COVID patients who were placed on ECMO, which are very challenging, as we've heard this morning, of course, with the Walker story and all throughout the meeting. Just a couple of goals that we're going to go after today. We're going to review some of the aspects of the management of these difficult patients and the associated challenges that occur once they're on ECMO. We all know the disease processes associated with COVID are different than we've been really exposed to for most of our careers. We're going to look at what occurred over the 24 months, and as I mentioned, look at registry data. When you start talking about ECMO, a lot of this is experiential. It's something that we basically learn. You know, there's so many courses that are out there. I worked at the University of Michigan with Dr. Bartlett back in the 80s and had an opportunity to train with him and learn. But even then, we really didn't know a lot of what was going on. And I think Pete Seeger, those are folkies in the audience right now, probably have heard some of his songs. But, he really said it best, is like education is when you read the fine print, and experience is what you do when you don't. And I think that really sums up a lot what goes on with ECMO. So let's talk a little about the history of the pandemic for ECMO. This paper, was basically an editorial that came out in JAMA early on, and said be cautious and apply ECMO only to those individuals who you really feel have a fighting chance. And remember, 2.5 years ago, or 2 years and 3 or 4 months, we really didn't have a good idea of what the outcomes would be with people putting on ECMO. Thank goodness we do now. But there were also editorials, letter to the editors, that occurred that said, you know what, these patients don't do well when they're placed on ECMO, so really carefully consider whether or not you should be applying ECMO. Everybody in this room here has had some experience with COVID patients. They've come not only from an ECMO perspective, but in the operating room, and there's been loads of papers in cardiac surgical management as well as surgical management of COVID that shows us that there's a unique aspect to it. So many of us develop these type of protocols. This one was thumbed up in an operating room. Actually, it was an ICU in regards to how to manage COVID patients. And then, as was already discussed earlier today and throughout the meeting, guidelines are ubiquitous. I mean, there's loads of guidelines out there on what should and should not be done. And what's important to keep in mind is this is an evolving data set. And some of the information that I'm going to share with you shows what really is unprecedented with most of us that have been involved in either a surgery, intensive care, perfusion over the last 40 years, because the rapidity of which this information is appearing has resulted in a lot of misinformation that is out there, and changes within pharmaceutical regimen treatments of these patients that we had not seen before. Normally there's multiple randomized clinical trials that are controlled, blinded, and really very few actually exist for COVID. And this is a summary slide of that. There's close to 1,400 publications on the use of ECMO with COVID. And there's so much heterogeneity within them. I mean, they exist from a single centers, and when you get to single centers, you'll see that they have the best results. When you can tightly control what patients you're going to be placing on ECMO and following, whatever guidelines, either national or your own, that you've established, your outcomes are going to be better. There's no doubt about that. But when you get into multi-institutional or registry data, that's probably a better depiction of what's going on throughout throughout the industry, and perhaps using those recommendations from those single center studies. But more importantly, we know, and we've heard, the Walker story this morning was phenomenal. We've all experienced this. This is definitely rationing of medicine. We all know that the recent Vanderbilt study has shown that most of these patients are dying. And I should actually back up a second, because right now we're really on the tail end of the COVID phenomena. Dr. Fauci yesterday came out and stated that the pandemic was over. And in fact, our numbers, which I'll show in just a little minute, in the last several months we have 92 hospitals doing ECMO, 61 did COVID patients. We're seeing a real tail off, thank goodness, thank God that that's occurring. So let's move into what I'm going to discuss once we get into the data, and that is the utilization of a registry to go ahead and collect information and then to place it into a central location where data scientists can get at it and provide advanced statistical methodologies so that it can be utilized. And we've written a number of papers on this. I think we're up to 9 right now. 3 or 4 are in revisions, but these are the ones that are at least are out there that have been published. And I'm going to summarize a lot of that information here as we go quickly through the slides. Early on, our first 32 patients, what we found was that there was a relationship with the age of the patient that was being placed on, the length of time that a patient was placed on, with survivors spending longer on ECMO than non-survivors. Followed up with 100 patients, that was 32. Then when we looked at 100 patients, we found that the individuals who were surviving actually were younger, and we'll talk a little bit more about that in just a second. Once we reached just under 200 patients, we looked at some of the pharmaceutical changes, medicine changes that were occurring across these 60 hospitals across America, and it was a seesaw pattern. This is so unusual and unprecedented in medicine. This is not something that we see often. Perhaps during Ebola or other pandemics that were breaking out, you saw the rapidity with which information and knowledge was being generated, and we found, of course, in retrospect, that knowledge probably was not accurate at times. So let's look at where these particular centers are. The graphic on the left just shows the states where these 61 hospitals were located at, and the blue stars just indicate where we've got centers that are doing 50 or more COVID ECMO procedures. We do about 1,100 ECMOs per year in our organization. And then the distribution curve on the right just shows the number, and there's a lot of variability here with outcome information that's related to the number of cases that are done. A lot of the modeling I'm going to present from here on out, it really isn't a confidence interval, it's credible interval. We shift to a Bayesian type of approach to our statistical analysis, which is what most of publications now are going to, or they will be going to in the next few years. So when you see these type of graphics that come up, traditionally they're a median and confidence interval. This now is credible interval, which is a little bit higher opportunity to predict how an outcome will be. And so what you can see is that over the time period of the pandemic, the number of cases that you're doing at the hospital has a direct relationship to overall survivability of the patients. What I'm going to do to summarize the next data that I'll be presenting is we're going to look at 700 and just under 40 patients. A bunch of them were lost. We didn't have outcomes, but we did have outcomes on 624, which are separated into a survivor category and a non-survivor category. If we look at the time that cases were placed on ECMO, this graphic right here, the horizontal axis on several of these will come up. We'll show you the months and the years. And I ended really at February. March is shown there, but it was really the end of February. And then if you superimpose on these particular graphs what was going on in regards to the various variants, I don't have more recent ones on here, but definitely Delta and the Omicron corresponded with those peaks that we saw with individuals being placed on ECMO. Majority of patients are suffering pneumonia. ARDS is the primary concern of these individuals. No surprise because of the target tissue that the coronavirus is focusing in on. Most of these patients are male. If you actually look up from a genetic perspective, women have an enhanced immune system. And since this is primarily immune dysfunction that is occurring with this particular type of pathology, women tend to be less affected in this than men. And then, of course, looking at the ages on the right-hand side, you can see that looking at the average, not the median, somewhere in the mid-40s. But if you distribute the categories shown on the x-axis here just by age, our IRB approval is 18 and above, so that's what we set at. And you can see the majority of patients are located somewhere between 30 and almost 60 years of age. Unfortunately, our research and others have shown that the older you are, the outcomes will change dramatically in regard to this. Again, no surprise, and I keep on referring to the Walker story with the 52-year-old Robbie, being perhaps at the cusp of whether or not he should receive ECMO. Ethnic distribution. We're going to talk a little bit about this more. This has become more prominent in the major journals. JAMA, New England Journal of Medicine, are requiring that any type of submissions right now do have an ethnic component and race, and we can see that this is primarily affecting the non-white population. But I'm going to keep this as a caveat because in a few minutes we'll go over the sequence of the pandemic, because this has changed dramatically from when we initially started looking at this information. Most of these patients are veno-venous cannulated, 91%, and of those that are cannulated, 75% are using a dual cannula technique, with about a quarter using one of the single dual stage catheters that are in place, and the distribution shown there with Protect, Crescent, and Avalon at the bottom. And we'll talk a little bit about more of that in just a second. As far as the time on ECMO, here's a distribution with VV versus VA. VA patients are spending about 5 days less on ECMO in regards to a median and an average. But if you look at the outcomes here, clearly if you have multi-organ involvement, which most of these individuals do, a lot of them have myocarditis, you'll find that there's less survivability within that particular type of cannula group. What devices are being used today? I'm sure everybody here, if we were to ask, you would say, yeah, I'm using the Rotaflow, the Centromag, or the CardioHelp. In fact, 75–80% of all the cases are using one or more of these devices, and then a small utilization of others that are out there. What about thromboprophylaxis? We know that anticoagulation is extremely important due to the disease processes associated with the hyperinflammatory response that we see. And that inflammation, of course, has tremendous crosstalk with any of the coagulation pathways, including platelet interactions. So coagulation management is huge. 2/3 of our patients are given heparin, and then we have about 20% or so that are using a direct thrombin inhibitor, either bivalirudin or agatroban. I wasn't able to find any others within our database. But if you look over on the right-hand side, from the mid to the right, you see that we have a transfer of patients who were on heparin and then went to bival, or they're on heparin and went to argatroban. Keep that in mind, because that's a really important aspect, as opposed to when you read studies, and there are a few of them that are out there, more are being generated, that looking at specifically a DTI for managing these patients. Some centers have just gone to DTI and don't use heparin at all. But some of the outcomes you have to be careful with. So we did a sub-study, this one's in review right now, of about 1,500 patients, and we broke them down into heparin only, a DTI only, or a heparin then DTI. And we combined bival and argatroban in small numbers there. And then we looked at subgroup analysis. So on the bottom left here, you can see heparin only direct thrombin inhibitors and heparin following with a direct thrombin inhibitor. And so we looked at primary endpoints of circuit failure, and then some pathophysiological endpoints. And what we had shown was, if you look on the horizontal axis here, we've got the 3 categories. This is by disease state: heparin only, DTI, and DTI after heparin. And the majority of patients in the ARDS group that are not suffering from COVID are receiving heparin primarily, with less patients in the COVID group are receiving heparin primarily. But a fair number, almost a quarter of the patients on the far right-hand side, the percentile, are getting a DTI after they received heparin. So what are some of the outcome measures? Initially, before we regressed this information with multiple linear regression, we found that there is a trend towards more circuit changeouts, 50% versus 24% in the heparin groups, and this is both groups combined, and that the number of circuit changeouts as an average per ECMO run was much higher in the DTI after heparin group. So once you start basically controlling for multiple factors, time on ECMO is a huge one, for example, which will be shown in the next slide. Once you get rid of all those, we still see this effect is prominent, where if you start with if you start with heparin and then go to a DTI, you have a much higher likelihood of changing out a circuit. And this information also was consistent with some of the outcome measures, renal, hepatic dysfunction, and as well as mortality. In fact, as I just mentioned, the ARDS ratio of going ahead and having a circuit change out was related to time. This is reported by others as well. You have a 7-fold greater increase of having a circuit change out the longer you're on ECMO, and our ECMO times for ARDS versus COVID are approximately twice as long with the COVID group. But once you control for that time, you still see a 2-fold increase with individuals who are getting higher circuit changeouts, regardless of the time on ECMO, as opposed to individuals either given heparin or a direct thrombin inhibitor itself. So clearly something to be concerned with in your centers when you have this, and probably it's something that would continue if you are putting an ARDS patient on and your COVID numbers decline. So what about outcomes? Overall, our survival rate is just under 39% for those 680 patients or so, 682. And if you look on the right-hand side, 91% of the patients are failed to wean. You can't separate them from ECMO, while about 10%, just under 10%, were weaned and then died more than 24 hours thereafter. So it's something that once you do get a patient off of ECMO, some of them are weaned from a compassionate perspective, expected to pass away right away, and they hadn't. But some, were weaned successfully and then succumbed later on, usually to thrombotic events. When you look at what caused the death itself, respiratory failure, failure to improve your outcomes, about 50% of the patients. And then the next three categories make up about 35%. Multi-system organ failure, cardiac arrest, and central nervous system injury. And a lot of that injury is related to thrombotic events, so it was hard to separate them out and tease them. When did people die? I know I didn't, I went quickly through the pandemic structure that's reported by Johns Hopkins, but if you look at those peaks with deaths, they correspond to usually 4 to 6 weeks after the COVID Delta variant and also the Omicron. So let's look at some of the changes that we had found. Most of this is descriptive until we get into a more finite analysis. We see that patients in the survivor group are younger, about 7.5 years younger than the non-survivors, more men in the non-survivor group, and then also, again, getting back to ethnicity. And why ethnicity is important, this paper just published in JAMA a few weeks ago looked at comparing the Mississippi inpatient-outpatient database, and I think it was 18,000 patients. And what they had found was when you compare whites, blacks, indigenous populations, Alaskans, even when you start controlling for factors such as the Native Americans and Alaskans are younger on admission and younger when died for COVID, and they're more likely to die in the hospital, this was not related to comorbidities. This was not related to a sicker population that was coming for intervention. And this is not ECMO patients. I'm sorry I didn't mention that. This is COVID in general. So there's something else going on related to genotypes that need further examination, because it's not just saying that this was more comorbid patients. We assessed the pre-ECMO comorbidities, and you can see the list on the left-hand side over here and the distribution. And when you look at them individually, there's no difference, but when you do a composite analysis, you group them all together, we have about a 6% increase that is occurring, and this has actually changed over the pandemic. Which is interesting. So once we get into the sequential outcomes, maybe this will help explain what we're seeing. And then, of course, we have all of these traditional ELSO-type measures, and there was no difference in most of these categories when we started looking at them individually or through regression analysis to see if there was a relationship. But this I draw to everybody's attention, and this is a dumb moment for me because you've all experienced this more than anybody, is the number of circuit changeouts. Over 35% of all patients, whether you're a survivor or non-survivor, had a circuit changeout. And if you look at the number of circuits, the number of patients who've had multiple changeouts, it really is impressive to see. And we know this is related to time on ECMO, but it is, those of us in perfusionists, I've been close to 40 years as a perfusionist. I've changed one oxygenator out of my life, in my career, and that one really did, when blood was pouring out of the exhaust port of the oxygenator, it's probably a good idea to go ahead and change it. But I'd never changed one. I've never come close to changing one any time in my entire career. If you're doing ECMO, if you're an ECMO specialist, which are probably all next door, or a perfusionist doing ECMO, you're changing these things out quite frequently. Looking at some of the pharmacological changes, I just took a snippet of them. These are quarters during the pandemic. Q1 20, which is when our first patient was March 17th, 2020, and then ended this past fourth quarter. you see this seesaw pattern that's occurring with pharmaceuticals, and it's really frustrating because a number of our intensivists and surgeons say if you've seen one ECMO run, you've seen one ECMO run. They're all so individualized. It's tough to make generalized statements on them. But if you look at veno-venous versus VA, we can see that in the non-survivor group, these are primarily multi-organ failure individuals dealing from a cardiac or hepatic and renal perspective. And sure enough, if you then look at survivors versus non-survivors in regards to timing, this first graph is diagnosis to intubation, from the time period that they were diagnosed with COVID till they were intubated. And we can see that the x-axis, which you can't read on the far graphic, that's time. And this is time from cannulation. So we see over the entire pandemic, the longer you spent from the diagnosis to go ahead and intervention being intubated, the worse your outcomes. Now, everybody in the room here is knowledgeable, of course, with barotrauma and mechanical ventilation, the duration being a prominent effector in regards to a negative outcome. But this is, even before you're intubated, that's shown this relationship. But once you were intubated and you're placed on ECMO, that relationship diminishes. In fact, if you look at, from about, I think that's 2 days out, there's really no benefit in regards to survivability once you get beyond just a few days from intubation to ECMO. And you can see the descriptive statistics on the left, about 4 days is what the time period is. So that helps. It helped us earlier in the pandemic to alert intensivists and the group if somebody wasn't getting better with the interventions that were being done. You've got about 2 or 3 days to get your ECMO resources in line. Support time, this is the blue is the average, the red is the median. And so on the left-hand side, you can see that non-survivors are on longer. It makes sense. You're trying to do everything you can, give them an extra couple of days. No difference in tracheostomies. There's a lot of research that comes out and says, perhaps we should trach these patients right away. Perhaps we shouldn't trach them. Perhaps no intubation should occur. If we look at discharge summary, now this is partial. I only have 142 patients that we have accurate data on, but there's really 6 places they can go: long-term care facilities, home, rehab, referring hospital, onto a transplant, and unknown. And then on the right-hand side is the days. So once you're off ECMO, the shortest days are usually the ones that are sent back to a referring hospital. Once they're left our facilities, we no longer have an opportunity to follow up on them. But you can figure between 25 and 30 days from the time period you're weaned off ECMO till discharge to the long-term care facility, or some patients actually home. What about the probability of survival over the pandemic? So if you look on the months and years on the very bottom and then fit that into a regression analysis, we can see this phenomena. This is very unique. Something that we've submitted, and it's being revised right now to the Journal of Thoracic and Cardiovascular Surgery, and it shows this U-shaped phenomena. The ELSO data was presented in Lancet about a year ago, and they had looked up till about the mid-level and shown that there was a decline in overall survivability of these patients. Well, we've shown that exact same decline that occurred, but now it's trending upwards again, and I'm sure the ELSO people will publish on this as well. So let's look at some of the really dramatic changes that have occurred throughout the pandemic. On the left-hand side, again, March 2020 was our first patient, and that's February, a couple of months ago this year. And look at the average age of patients that are declining that we're placing on ECMO. And that could perhaps tell us why we're seeing that inflection with more patients surviving during ECMO. And now, if we look at some of the changes, look at the ethnicity changes. Latinos were the primary group that were found in a total descriptive statistical analysis by summarizing all data, and they're actually dropping off significantly. And more whites, Caucasians, are actually ending up being placed on COVID as an overall percentile, and the African Americans are following those same trends with Latinos. As far as some of the drugs use, and I put this up because it shows the seesaw pattern. Here's a percentile, right? But if you look at what occurred, this paper, 2 papers came out in the New England Journal of Medicine. The first one, basically damned monoclonal antibodies as being effective in patients who were critically ill, suffering from COVID pneumonia. But then, at this time period, you could see the red arrow is actually showing when the publication occurred. This showed the opposite, that actually IL-6 antagonists actually probably are beneficial. So you get this sawtooth pattern in drugs that are occurring. Now, if you're a researcher and you've been involved in the pharmaceutical industry for years, the x-axis here isn't in months, it's in years. You know, phase 1, phase 2, phase 3 trials, phase 4 trials. It could take 20 years for this information to develop. Here we're developing it in a very short period of time. So it's something to keep in mind. This is unprecedented, at least in my 40 years in my career. No surprise, hydroxychloroquine. It's interesting, though, that some patients are still coming and are being given it in a few centers. And then on the right-hand side, steroids. You know, it was a dollar fix. It was something that's been shown to be very effective in managing COVID, and so most people are doing that right now. Convalescent plasma, this was really thwarted to be a really phenomenal achievement, especially from a blood banking perspective. Unfortunately, some good data threw a curveball at that wonderful theory and caused it to be to regress. And so now you can see, in fact, in our last 4 or 5 months, nobody has received convalescent plasma. Cytosol filters, these were, you know, they make perfect sense to use them. I mean, there's nobody who can argue against that. There's been a lot of European trials, some here in the country, that have shown they've been efficacious, not only in COVID, but in severe inflammatory response syndromes and others. Just nobody's using them. We just don't have any utilization. And all that could mean is that the hospitals that are in this data set don't use it because others have really embraced the technology. And here's just a paper that came out and said that they probably are not effective. Looking at some of the subcategories before I conclude, this is pregnant patients. And we had 15% of all of our women in our trial were pregnant or peripartum. These were individuals, and you can see 28 of them were postpartum, and then the C-sections and fetal death and a few unknowns. 55% survivability, which is 15% higher than our average for the entire population. So, and these are young patients. Their average median, was 32. Most of them are on VV ECMO. And then you can see the distribution of time period, including the days of support. The majority of these patients were Latino, and that makes sense. And if you look at some of the recent data that has been published on pregnant outcomes with individuals placed on ECMO with COVID, you can see that the very top distribution on this forest plot is showing survivability is much greater, is high with these individual patients, women who were pregnant post, which is great. And the very bottom here is renal complications, acute renal failure. New onset renal failure was also significantly less if you were pregnant. So really good things to know and offering hope. Some of the outcomes that don't fit into any type of graphic, our longest survivor support time was 128 days, but our longest patient is still on today is at 453 days. And if my memory serves me right, there have been no circuit change outs. I don't know if any of the clinicians involved with this management is a Floridian patient. No circuits have been changed in over 300 days on ECMO, which, correct me if I'm wrong if any of the clinicians are here. Shortest time on ECMO, 2.4 days. We don't include 1 day. If you're on ECMO for 1 day in COVID, you get placed in a different database, for a number of reasons that I won't necessarily go over. And then off ECMO, but then reinitiate a very small percentage, where you're off and then come in. So to conclude, just a few summary slides, and this is really the unknowns. There's so much that we don't know with this particular management, even though we're now over 50 years using ECMO as a modality for treating these very sick patients. Do you extubate them? Do you intubate them? Do you perform a tracheostomy? Do not? What's the effective timing here? We all know it's better to be placed on ECMO sooner than later. What about the selection criteria? What type of risk modeling are you doing to determine who should be placed on ECMO or not? There's a number of these that are out there. And then what type of cannulation are you going to use? So over the 24 months, some of the findings, there have been a change in pharmacological interventions that have occurred. There's circuit changeouts that are really important to keep in mind. And even though ELSO says, yeah, it's just related to your time on ECMO, that's not found. One of our studies had control for that time on ECMO and found still that there were more circuit changeouts with COVID. The use of DTIs is growing. More centers are at least going to it. Unfortunately, if it's done after you started with heparin, the outcomes tend not to be as good in regards to circuit, keeping the circuit intact. Survivors are younger, female, supported with VV more than veno-arterial. They have shorter time periods, and they also have lower pre-ECMO comorbidities. So the take-home message is ECMO is definitely a viable option. I think that's been well established by multiple studies that are out in the literature right now. Early hesitancy with applying ECMO has really been found to be not true. Adjunctive therapies are occurring at a rapid rate. I mean, that's why if you look at how this is being published, it's remarkable that the editors of the journals and reviewers that review these papers allow some of them to come through. And I've noticed over the last few, maybe year and a half, it's a lot harder to get papers published today right now. In fact, I got a review today from one of the editors, and he said, he goes, basically, this is redundant. Which you hate to say, especially to an editor. Well, replication, scientific methodology is based upon replication, so it may be redundant, but maybe you just don't want to put paper to pen here and have it published. That's my little rant. But I mean, it is important to realize that this is evolving knowledge that is occurring over time. And the results of higher circuit complications are something we just need to be aware of. Maya Angelou, wonderful individual, Dr. Maya Angelou, wonderful quotes. I've learned that people will forget what you said, but they won't forget what you did and how you made them feel. And I think this morning's story that we were so lucky to hear probably brings that home. So with that, I want to thank you. This was last night's from our hotel room. My wife and I sit out with a glass of wine and watch this, and we just happened to catch this pelican going by. In Pennsylvania, where I live in the mountains, we don't have many pelicans, and we surely don't have many harbors. So it was a pleasure, and I want to again thank Carla and Susan and the entire committee for allowing me to be part of this conference. Thank you.